Lupus Unraveled opens by framing the talk. We will explore scientific insights, strategic analysis, and future pathways in lupus research and care. The title slide highlights clinical research, market dynamics, therapeutic innovation, patient outcomes, and global impact, setting the stage for a discussion that moves from biology to diagnosis, treatment strategies, and emerging opportunities in patient management. This timeline slide walks us through key milestones in our understanding of lupus, starting with the term's Latin roots describing erosive facial lesions, the discovery in 1948 that linked lupus to autoimmune processes, the therapeutic revolution of corticosteroids in the 1950s, later refinements in diagnostic antibodies, and finally, the improved 2019 classification criteria that standardize diagnosis and clinical trials. The genetic architecture of lupus is complex, combining a broad polygenic risk landscape with some rare monogenic forms. Over 100 loci contribute risk, notably HLA-DR2 and DR3 haplotypes, while complement deficiencies like CO1q, C2, and C4 represent rarer but high-impact causes. The slide also shows how polygenic risk scores are being developed to predict disease onset and guide surveillance, especially for first-degree relatives with markedly elevated incidence. This diagram summarizes environmental, infectious, and hormonal triggers that precipitate lupus activity. Ultraviolet light can induce apoptosis and expose nuclear antigens that trigger flares. Infectious agents, such as Epstein-Barr virus, may promote molecular mimicry, and certain drugs can provoke disease. Hormonal influences, particularly estrogen, enhance autoreactive B-cell survival and help explain the female predominance seen in lupus. The pathophysiology slide shows a cascade from loss of immune tolerance to immune complex-mediated tissue damage. Autoantibodies like anti-dsDNA, anti-SM, and anti-phospholipid antibodies form complexes that deposit in glomeruli and vessel walls, activate complement and recruit neutrophils, and ultimately drive inflammation and organ injury, such as lupus nephritis and vasculitis. Here, we focus on T-cell imbalance and defective clearance of apoptotic cells as central drivers of pathogenesis. A shift toward fewer regulatory T-cells and more Th17 activity, alongside interferon alpha signaling, amplifies autoantibody production, while impaired removal of dying cells leaves nuclear antigens in place, sustaining chronic immune activation and producing flares across multiple organ systems. The cutaneous manifestations slide highlights visible clues that often prompt further testing. Classic signs like the malar butterfly rash that spares the nasolabial folds, discoid scarring lesions, and photosensitivity are shown alongside frequent accompaniments such as oral ulcers, alopecia, and levato reticularis, all of which serve as practical markers of underlying disease activity. Lupus nephritis and neuropsychiatric features represent two high-impact clinical domains. Renal involvement affects up to 60% of patients, ranging from asymptomatic hematuria to nephrotic syndrome and rapid renal failure, while brain involvement can cause seizures, psychosis, and cognitive dysfunction that sometimes correlate with anti-NMDA receptor antibodies, necessitating timely and sometimes aggressive immunosuppression to prevent lasting damage. The 2019 EULAR ACR classification criteria use an obligatory ANA entry requirement, followed by weighted clinical and immunologic domains to reach a diagnostic threshold of 10 points or more. The slide schema shows how items from renal and neurologic domains carry higher weight, and explains how these standardized rules have improved earlier recognition and the quality of clinical trial enrollment. This diagnostic and management pathway ties routine testing to decision-making. Complete blood counts reveal cytopenias. Serologic biomarkers like elevated anti-dsDNA and low C3-C4 indicate active disease. urinalysis with cellular casts, guides nephritis evaluation, and renal biopsy with WHO classification staging, directs therapy intensity and prognosis for kidney outcomes. The Therapeutic Innovation Overview outlines practical treatment goals. Hydroxychloroquine remains the backbone for flare reduction and thrombotic risk mitigation. Glucocorticoids provide rapid symptom control, but require careful balancing of side effects. Steroid-sparing agents, such as mycophenolate or azathioprine, support remission maintenance, and salvage options like cyclophosphamide or rituximab are reserved for refractory nephritis or CNS disease. The final slide details emerging targeted therapies and trials. Belimumab blocks BAFF to reduce autoantibody levels and flares. Anifrolumab inhibits the interferon alpha receptor, improving skin and joint manifestations. BTK and proteasome inhibitors aim to suppress B-cell signaling and modulate immune responses. And early KART approaches seek to reset immune tolerance, offering a potential route to precision control with fewer global immunosuppressive effects.